heard a great panel discussion this morning about Marianist scholarship, and I heard an engineer say that he was challenged to think how his scholarship can be linked to the Marianist heritage. For me, as a caregiver with over 20 years of the art of healing, everything that we do is giving back to the community and giving back to the individual. So for us in physical therapy, it seems to be a very easy linkage, and I hope that you see that today. So 12%, that's the lifetime risk for women to develop breast cancer. When we look at the numbers, over 232,000 people will be developing breast cancer this year alone. Of that, approximately just under a third are non-invasive early stage cancers. You might hear that as stage 0, or DCIS, stands for ductal carcinoma in situ. But the remaining cancers are the more invasive later stage cancers. The most commonly diagnosed cancer among women is breast cancer. So as such, I see a lot of these patients in my clinic. That 12% risk translates to a 1 in 8 lifetime chance of developing cancer. There are cases of breast cancer among women in their 20s, but they're rare. As you can see, the risk increases over your decades. So 1 in 233 in the 30s, rising as high as 1 in 27 in the 60s. So the greatest risk factor for breast cancer really is age. There may be some things we can control with diet and exercise, but it seems that the greatest risk factor is indeed age. We have good news, though. More women are living beyond breast cancer. Today, more than 2.9 million women in the United States have survived breast cancer at least 5 years. The 5-year survival rate is up to about 91%. That's a 25% increase since 1975. That survival can be attributed to aggressive screening and treatments to detect cancer early and treat it. So, as the emphasis in the healthcare world has moved from can we help keep these people alive, we're starting to look at quality of life. Arm function, the ability to do our daily tasks, is an integral part of our quality of life. I am not sure that all of us have thought about the impact of not being able to use our arm on a daily basis. So that's where I'm focusing today. The aggressive treatments that we've used to create that 90.5% survival rate has, in turn, impacted the ability to use the arm. So let's think about what we do. We got to lift our arms up to wash our hair. We've got to reach the cookie jar. We've got to lift groceries or carry some really important cargo. These are everyday activities. None of this is high function. This is everyday activities. If you want to think about high function, perhaps we'll think about overhead sports such as tennis. Or I like these slides. These are dragon boat racing. And there are breast cancer survivors, see all the nice pink shirts, that participate in this really aggressive sport. If we don't have adequate arm function, they can't return to this level of activity. I would like to also point out, if you look really closely, there's some pink sleeves going on here in these women. I'll come back to what those are. So how does a physical therapist measure arm function? We can do a self-reported measure. We can find out what people think they can do and not do. One of the more common ones is called the DASH, the disability of the arm, shoulder, and hand. But we also measure objective measures. We look at how much motion folks have, how much strength they have, and their muscular endurance, or their ability to continue to use their arm over time. So why is this important? Nearly every woman diagnosed with breast cancer will have a surgery. The most conservative surgery is called a lumpectomy, often called a breast conserving surgery. A mastectomy is a much more aggressive and involved surgery. It removes more tissue. And an axillary node dissection is a fancy word for saying we're going to take the lymph nodes out of your armpit. So I wanted to show you a little bit of what this looks like. I apologize if this is offensive. The incision site for a lumpectomy or breast conserving surgery is rather small. They remove only the tumor and as much clean cells around the tumor as they can get. A mastectomy is going to be much more involved. This silhouette here shows the extensive amount of tissue that's removed. I think most people have an image that the breast tissue is rather round. However, there is actually a little tail of pence that comes up underneath the armpit, so that's why that silhouette extends up. And this also shows the lymph node connection to the breast tissue. These white spots are cancer tumors. Now this incision is actually not a really good picture. Most mastectomy incisions are a horizontal line across the chest wall and a small incision in the armpit. So that's a little bit more extensive. And lastly, I want to give you a visual of where these lymph nodes are located in the upper arm area. We have quite a few in the front of the chest and into the armpit. We have some up against the breastbone here. And all these are related to where the fluids flow from the breast area to return the fluids back to the heart. So again, why is this important? The treatments that we use outside of surgery are also damaging to the arm. We've got chemotherapy. This is a non-specific medical treatment. They are getting better at targeting just cancer, but in general, chemotherapy agents target rapidly dividing cells. So they're not going to discriminate and only pick on cancer cells. They're going to pick on all rapidly dividing cells. They interfere with replication. Radiation, this is the most common radiation used. It's called external beam radiation. It does intend to try to get the breast tissue. This would be used for a lumpectomy treatment. But as you can see by this beam here, we're also hitting the rib cage and into the armpit and all the tissues that are in its path. So it is, again, not limited to the breast cancer cells themselves. The problems develop often from the surgery and these adjuvant treatments. Radiation fibrosis is a phenomenon where the tissues tighten up and get very stiff. We know from the extreme cases of Nagasaki and Hiroshima that this occurrence continues for 7 or 8 years past radiation treatment. Granted, our patients are not exposed to that level of radiation, but indeed, the fibrotic changes in those tissues occur for 7 and 8 years after treatment has been discontinued. The chemotherapy is also very toxic not only to the heart. It can actually damage the heart, which affects your aerobic capacity, but it often results in peripheral neuropathies where you get numbness and tingling. If you have that in your hands, you lose your fine motor control, you drop things. If you have that in your feet, you often damage your balance abilities. And then there's a large concern over developing lymphedema. If we've irradiated those tissues in the armpit where those lymph nodes are, or if we've done surgery and removed those lymph nodes, we've destroyed the body's ability to transport fluids out of the arm. So lymphedema looks a little bit like this. The picture on the left is a mild case of lymphedema. We can still see some definition in the hand and some wrinkles, whereas the picture on the right is a much more severe case of lymphedema. We've lost hand wrinkles and definition. We've almost got this tight band of restriction around the wrist. As you can imagine, somebody living with this large arm, it will impact their daily function. So typical treatment, this is what I see in the Dayton region. It does vary nationally. If you have a lumpectomy, there's minimal precautions. You can return to your activity level. If you have radiation, they teach you about caring for the skin, keeping it compliant, trying not to expose it to too much sun. If you've had a mastectomy or axillary node dissection, the standard of care is that you watch your arm motion for approximately 2 weeks after surgery. They have drains installed. They want to make sure all the drainage has stopped and the drains are removed before you can go back to using your arm. And then they say, we'll follow up in a few months and see how your blood cells are looking. And they don't refer patients to physical therapy. So what I wanted to know was, given the aggressive treatments, normal healing times, are women able to return to full function? And I'm looking at a year plus. I'm not looking postoperatively when I know their function will be limited. Are women able to use their arms? Or, since I get these patients, are the changes that they're reporting to me, I can't reach as well, I'm not as strong, How they do to aging. So is cancer the scapegoat and everybody loses motion and strength with age? Or is cancer the problem? So in my study, I measured quality of life using a couple questionnaires and self-reported function. And I measured motion. I did the forward reach. This is your cookie jar. Can I reach up on that high shelf? Hand behind back. This is very clinically applicable for women. We fasten our bras this way. We reach in our pockets this way. And I measured this external rotation motion, reaching back in the car, opening a door, that sort of activity. And I measured strength of all of those motions as well. Additionally, I measured muscular endurance. Now, this has not been looked at on a common scale in breast cancer survivors. I've only seen 2 other studies that have done it. There isn't a standardized way to do it. I used a test where the participants lifted a 1 kilogram weight up and down off of the shelf at a metronome pace of 1 beat per second for up to 5 minutes, and fastened and unfastened bolts, moving them in this metal plate up and down, again, for up to 5 minutes. You can see it does take adequate range of motion. It also takes a certain amount of stamina. Patients were stopped from completing this test if they couldn't keep beat with the metronome, if they just told me they couldn't do it any longer, or if they couldn't do it in the proper order. So what did I find? I found that overall, breast cancer survivors reported lower quality of life. They also reported higher levels of disability related to their arm use. So on that DASH scale, there was a dramatic difference between the breast cancer survivors and the people who had not had breast cancer survivor. They had lower levels of reach up behind their back and rotation across the board. And then if they had cancer on their non-dominant arm, they also had a little bit less strength. There were no differences between groups for muscular endurance. That's something we're continuing to look at. I suspect it may be the test and not necessarily that there is no difference. So what comes next? If these women, more than 1 year out, are still having problems, what are we doing now? I am collaborating with a National Institute of Health research study looking at breast cancer survivors in a prospective way. So in this situation, breast cancer survivors are having all these measures taken preoperatively and then postoperatively at that about 1 month range, and then 3, 6, 12 months, 18, and 24 months, all the way up to 5 years. And we are tracking their problems as they develop. The nice thing is that this is a clinical research study, so a therapist sees them, and as soon as they find a problem, they can address it. So one of the things they do is they provide education. When can you do things? How much can you do? They base their treatment and customize it on the specific problems that those patients present with, as opposed to, here's a sheet of exercises that the doctor gives you. Here's some examples. This is addressing that forward reach. This is forward reach into the side. This stretch, we call it sort of winging, stretches the chest and armpit area, and this one stretches the chest and armpit as well. We can strengthen as well. We're focused here on the shoulders or the biceps or the triceps. I also spend quite a bit of time strengthening the shoulder blade muscles. If you don't have adequate shoulder blade strength, you can't do a lot of activities. It's a stable base for your arm. So I spend a lot of time doing that as well. In that NIH study, there was a really important finding. They were able to pick up the onset of lymphedema before it became clinical. So the clinical were those pictures with the swelling in the arm. By then, it's almost too late. They were able to determine that a 3% difference from baseline to present is a subclinical onset of lymphedema. These women were aggressively treated, they were taught how to manage their lymphedema, and they were issued sleeves to provide compression to their arm. In many cases, they were able to reverse the onset of lymphedema. And this is a profound finding that can change the incidence and occurrence of lymphedema among breast cancer survivors. These are some of the treatments that women with lymphedema receive. This is that CLT alphabet soup after my name. We perform a specialized massage called manual lymph drainage. We wrap the arm with compressive garments. There's padding and foam and elastic wraps. This is worn 23 out of 24 hours a day to provide compression to the arm. As the lymphedema reduces and becomes stable, we provide garments that provide compression to the arm. And then some women who have more trouble managing their lymphedema than others often even have to wear this padded sleeve at night to sleep with. There are other ways to manage lymphedema. There's a team of researchers out of the University of Pennsylvania that debunked the myth that strength training is damaging for breast cancer. And they showed that resistive exercise training actually can help reduce lymphedema. So I wanted to find out, since yoga is very popular, can yoga do the same thing? And I'm currently working on that study. Preliminary results show that it's at least safe. I'm not sure I'm showing a change yet, but we'll see where that goes. So to kind of wrap this up, this is my dream. I'm a clinician as well as a scholar. My dream is that the Dayton area physicians, because this is where I am, this is where I'm working, understand the importance of early intervention, of prospectively following breast cancer survivors to prevent the problems from developing. I want all women in on a regular basis, and I want to develop this awareness that problems can both be prevented and treated.